I am Teresa Larson. I am a researcher for the Transforming Communities Institute, and I will be the technical facilitator for this meeting and for this session, sorry. If you have any questions specifically related to the tech or to the continuing education portion, you can contact me directly. You can do that through a private message in the chat or a public message in the chat, whatever works for you, or via email. You should all have it. It was connected to the meeting invite that you got earlier. And before we get started, I do want to provide the USU land acknowledgement, and that is as a land grant institution, Utah State University campuses and centers reside and operate on the territories of the 8 tribes of Utah, who have been living, working, and residing on this land from time immemorial. These tribes are the Confederated Tribes of the Goshute Indians, Navajo Nation, Ute Indian Tribe, Northwestern Band of Shoshone, Paiute Indian Tribe of Utah, San Juan Southern Paiute, Skull Valley Band of Goshute, and White Mesa Band of the Ute Mountain Ute. We acknowledge these lands carry the stories of these nations and their struggles for survival and identity. We recognize elders, past and present, as peoples who have cared for and continue to care for the land. In offering this land acknowledgement, we affirm Indigenous self-governance history, experiences, and resiliency of the Native people who are still here today. So thank you all for joining us today. I know a couple folks came in after I gave the initial announcements, but please make sure that your Zoom name matches the name that you would like on continuing ed. That is how we determine that you actually attended when you take the evaluation survey. And there is an evaluation survey that will be sent out after the meeting. I'll put it in the chat as well as it'll be sent via email. But that will arrive at the end of today's session. If you have any questions during the session, whether that be for myself or for Mandarin, who is our presenter today, you can put those in the chat, but we will save some time at the end for questions about the presentation specifically. And I will now introduce our presenter. So Mandarin Labrum is a licensed marriage and family therapist who runs her own practice, private practice called Mandarin Lin Counseling in Vernal, Utah. With a passion for helping individuals and families navigate life's challenges, Mandarin brings a wealth of experience and expertise to her therapeutic practice. She earned her master's degree in marriage and family therapy from Virginia Tech and her bachelor's of science in psychology from Utah State University. She has over 12 years of professional and clinical experience working with at-risk youth, active duty military personnel, individuals with eating disorders, trauma, anxiety, depression, suicidal ideation, and those with relational and intimate issues. Mandarin has worked in residential treatment centers, outpatient centers, community mental health centers, and private practice. While at Utah State University, Mandarin was inspired by her early experiences working with adolescent girls at a residential eating disorder treatment center in Logan, Utah. And while observing these girls transform from resistant, hopeless, and fragile individuals to hopeful, vibrant, healthy agents of change, she discovered her calling to be a therapist. From there, she changed her major and started on her career path to become a therapist. And as a therapist, Mandarin values her eclectic approach, integrating multiple modalities to provide a client-centered and systemic framework. And in her practice, she fosters a non-judgmental and inclusive atmosphere where clients feel heard, understood, and are challenged to reach their goals and create adaptive change. So thank you, Mandarin, for providing today's training, and the time is now yours. And for those that are just joining us, don't forget you can ask questions in the chat.
Awesome. Thank you, Teresa. So as she had mentioned, my name is Mandarin Labrum. I live in Vernal, Utah, and I have my own private practice. I felt grateful that Teresa reached out to me to present on this topic because it's something that is I'm very passionate about, given that that's kind of what set me on my path to become a therapist. So a little bit about the treatment center I worked at. I will probably talk about some of the clients that were there because that definitely framed my view, and it was a very good, those case examples that I received were great. But Avalon Hills is a residential eating disorder treatment center just outside of Logan, Utah. There, it's usually the length of stay is between 9 months and 18 months. And most of the girls who came there were from out of state, sometimes were even from out of country. Avalon Hills was very much known for kind of like the last resort. So a lot of these girls came straight from the hospital. They were extremely sick, whether it be extreme malnourishment, extremely underweight, or having just attempted suicide and had been in and out of other types of treatment centers, and it was just not effective. And so they ended up at Avalon Hills. At that time, I was trying to get my bachelor's in secondary education. I was thinking about becoming a teacher and quickly changed career paths and went down this road. So with eating disorders, I think it is one of the most prevalent clinical diagnoses that exist, but misunderstood and misrepresented. So that is one of the reasons I like to spread awareness about it and to treat people, or not treat people, but train people on it, just because it is something that most of you, if you're working with clients, have people in there who have disordered eating or actually meet criteria for eating disorder diagnoses. And hopefully this presentation can help give you a little bit more confidence in being able to assess for that and then know a couple of strategies and skills to treat. So if you guys have questions, I am happy to answer questions as we go along, or if you want to hold them till the end, that's fine as well. So to start, I thought we would just start with some general statistics. Let's see here. So in general, 9% of the population, or 28.8 million Americans, have an eating disorder or have had an eating disorder at some point in their lifetime. 15% of women will suffer from an eating disorder by the 40s or 50s. The sad thing is, even though that is such a high number, only about 27% receive treatment for their eating disorder. There are fewer than 6% of people with eating disorders who are considered medically underweight. So I think this is one of the biggest misconceptions. You know, they assume that, oh, you'd be able to identify if they have anorexia nervosa or if they have an eating disorder because they would be like really like fragilely thin, or they would be like so thin that it was just kind of like bone and skin. And it's at times the case, 6% of the times it's the case, but very rarely is it actually that way. In a sample from an American emergency room, 16% of all adult patients screened positive for an eating disorder. So even if they weren't coming in for that reason, it was interesting that they self-reported that they had an eating disorder. Anorexia has the highest case mortality rate of any mental health illness. 10,200 deaths each year are the direct result of an eating disorder, and that's one death every 52 minutes. And patients with anorexia have a high risk of suicide 18 times higher than those without an eating disorder. So with eating disorders, it has a very high comorbidity rate with other mental health illnesses as well. So I just listed some of the main ones up here and talked about the percentages with it. So anxiety and depression is the main thing that you see along with somebody who has a diagnosed eating disorder. Over 70% of people with eating disorders also have other conditions, most commonly anxiety or mood disorders. Type 1 diabetes is very common as well. In a study, girls with type 1 diabetes aged 9 to 13 were evaluated for 14 years. By the time they were in their 20s, 40.8%, so almost a little less than half, had met criteria for a full or sub-threshold eating disorder, and 59% took part in dangerous disordered eating behaviors. ADHD, 6 to 17% of eating disorder patients also are diagnosed with ADHD. Girls with ADHD are 3.6 times more likely to have an eating disorder in general and 5.6 times more likely to have bulimia nervosa. And then OCD, 10 to 35% of patients with eating disorders also have the diagnosis of OCD, or obsessive compulsive disorder. For children, this is one of those mental health conditions that can affect you across the lifespan. Girls, they start to worry about their weight between ages 6 and 10. By 14, 60 to 70% are actively trying to lose weight. 77% of children and adolescents as young as 12 dislike their bodies, and 45% say they are regularly bullied about how they look. Girls who were teased about their weight were 2 times more likely to be overweight, 1.5 times more likely to binge eat, and 1.5 times more likely to use extreme methods of weight control 5 years later. 22% of children and adolescents have unhealthy eating behaviors that could lead to or indicate an eating disorder. 8% of 15-year-old girls died at a severe level, and the risk of developing an eating disorder was 18 times greater than non-dieting peers. 12% of adolescent girls have some form of an eating disorder, and only 20% of adolescents with eating disorders actually seek treatment. There's multiple reasons for that. The resistance to treatment. One, sometimes they are in denial they have an eating disorder. Two, sometimes they might acknowledge that they have it, but they don't see it as a big deal, or they see it as like a positive, like because I have this disordered thinking, it keeps me skinny, it keeps me healthy. Or because they are just really good at being secretive about it and they don't actually want that help at that time. So males also experience eating disorders, and it is on the rise at this point, whether it be because of the need or the social media of just presenting very muscular men, but also the thin aspect is very much part of the male generation at this point as well. Men represent up to 25% of people with eating disorders at this point. So that's 1/4 of the people who have eating disorders are men. In 1990, 1 in 10 men had an eating disorder, so it's increased quite significantly. Today, that number has risen substantially, and they say approximately 10 million American men deal with an eating disorder in their lifetime. Men are often not diagnosed or misdiagnosed. Women are up to 5 times more likely to be diagnosed and 1.5 times more likely to be treated for an eating disorder than men are. So part of the problem here is just men with eating disorders tend to minimize their symptoms. There's a lot of shame, and like there's a stigma that women are the ones that have eating disorders, or it's a woman's problem. So they're either embarrassed or, like I said, shame, or they just discount the severity of it and they're like, it's not a big deal. So as we are talking about eating disorders today, there are some common acronyms that I use. I just wanted to put these up here in case you're like, what does ED or AN stand for? So eating disorders, often represented as ED, anorexia nervosa, AN, bulimia nervosa, BN. Talk about body mass index quite a bit, BMI. And then the ANAD, which is where I was getting a lot of those statistics, most of those statistics, and that's the National Association of Anorexia Nervosa and Associated Disorders. So let's see. So Teresa's going to kind of monitor the chat. So if we end up having questions, if somebody, Teresa, if you'll kind of let me know, but we'll start to go into kind of just like what the DSM-5 kind of identifies for diagnoses with eating disorder. So in the DSM-5, it's not actually under eating disorder, it's listed under feeding and eating disorders. And so we'll go through some of these really quick. I'm not going to go into detail on all of them. The 3 that I'm going to really touch on today is anorexia, bulimia, and binge eating disorder. So I want to just hit on what the other ones are. So first we have PICA. PICA is the persistent eating of non-nutritious or non-food substances over a period of at least 1 month. Usually there has to be an inappropriate level. It's inappropriate to their level of development. So if it's like a little toddler who's trying to eat chalk, that's going to be different than if it's a teenager who still eats chalk or eats their hair or crayons or sand or any of those things. And they also say it's not due to another like medical condition. So if you're low in a vitamin or anything like that, and you are craving sand, or they say like sometimes pregnant women crave certain things that are non-food items, it would not be associated to that. Rumination disorder. Rumination disorder is the repeated regurgitation of food over a period of at least 1 month. Typically, this is associated with gastrointestinal issues. So this is not necessarily a condition that is tied to the fear of being fat or the desire to be skinny. It is more, there has been some form of trauma that has happened in the GI tract that has then elicited this regurgitation aspect. Regurgitating food, sometimes they just re-chew it and swallow it back down. Sometimes they spit it out, but most of the time it's re-chewed or re-swallowed. There are some conditions where with somebody with bulimia nervosa or anorexia, they will end up causing damage to the GI tract and therefore develop rumination disorder. So one of the girls that I worked with at Avalon Hills, that residential eating disorder treatment center, had rumination disorder, even though she was 1 year, for the entire year that she was in remission. So she was there for a good 18 months. She had had an eating disorder for about 6 years and had done quite a bit of damage to her kidneys and her organs and her GI tract as well. So it would be a consistent thing, not just when she ate. It wouldn't just happen like one time after she ate, kind of like an acid reflux result. or any of those things, or like a baby that's spitting up. This was more just throughout the day as it went along. It would happen more often, like after she ate, like hour or two after eating, but it happened quite frequently. She wouldn't like make the throw up sound. It was just this regurgitation, and you could see her kind of chewing and then like re-swallowing. Next one is the avoidant restrictive food intake disorder. This one is seen primarily in infancy and early childhood. It's not as much something that they see in later adulthood. This one is more the avoidance of food because of lack of interest in it, not because, again, the desire to get fat. So pica rumination disorder and avoidant restrictive food intake disorder are not necessarily due to fear of getting fat or any of those things. It's more just other causes. So other causes that can make people avoid or restrict food intake that are not related to diet is preoccupation with like other things. So like some people have like sensory issues. They said like people on the autistic spectrum, sometimes they just don't like the way taste smells, taste feels, taste, or food tastes, or any of those things. And so they will then just really limit what they allow their body to intake. This can do a lot of like the same, cause a lot of the same issues where like failure to grow, significant nutritional deficiencies, dependency on oral supplements or feeding tubes. And it's one of the caveats though is it should not be due to lack of availability of food. So if somebody is like extremely poor or not, doesn't have access to food and then ends up restricting their food intake due to like lack of means, it wouldn't fall under this criteria. So I'm going to kind of skip over the anorexia, bulimia, and binge eating disorder because we're going to address those in detail next, but I wanted to hit on the other specified feeding or eating disorders, OSFED. There's like 5 or 6 different ones under this category. So the atypical anorexia nervosa, this one, all criteria is met for anorexia, but they still are within a healthy BMI. So bulimia nervosa, low frequency. So they still are experiencing the bulimia, trying to exput or purge some of those things, some of the food, but they're not doing it in as high frequency to meet criteria for bulimia nervosa. Binge eating disorder, the same thing. They're still binging. They're just doing it in lower frequencies. Purge disorder is an absence of binging to manage weight. And then the night eating syndrome. Night eating syndrome isn't like when you're taking medication and you don't realize it, but you're eating at night. Night eating syndrome is like you're after having dinner, you've already like felt full for the night, but you have this like compulsive urge to eat large amounts, and not a binge, but like just more prior to bed, or you wake up in the middle of the night and you feel like you have to eat to be able to fall back to sleep. And usually there's a significant amount of distress that is correlated with that to meet this criteria. Let's see. For some reason, whoa, sorry about that. Okay, so we're going to go on to the criteria for anorexia nervosa. So this is for the DSM-5. There are some differences and changes that happen from going from the DSM-4 edition. So if people are like, oh, that seems like it's changed, it might have. So for it to meet criteria for anorexia nervosa, there has to be restriction of energy intake relative to requirements. So if on average you need 2,000 calories a day and you're only taking in 1,200 or 1,500 and it leads to a significant low body weight, then it would fall into this criteria. Intense fear of gaining weight. So even if people are on a diet and they're actually losing weight and it's intentional, but they're not doing it out of like this fear of gaining weight, then it wouldn't fall into this category. You would have to have that fear. You'd also be disturbed by one's body shape or size. There's low self-worth to your body shape or size, and there's a failure to recognize the seriousness of low body weight. There's 2 types we try to kind of classify these in. The first one is the restricting type. So the restricting type is one that just like does not eat and just really restricts what they put into their body. There's not usually a purging or a binge eating cycle. The binge eating purging type, they try to let it go through excessive exercise or other means. Let's
Mandarin,
sorry. Yeah.
just real quick, we do have a question in the chat that you might answer later on, but they're asking, do you know the percentage of geriatric clients affected by anorexia? and how it might be diagnosed differently.
So
Based
I
on-
don't.
Okay.
Through my research and like through my work with clients, oftentimes clients don't reach geriatric age if they have an active ongoing eating disorder, because your body's already deteriorating at that point. You die of natural causes, or sometimes you die because of eating disorders. Like, as I shared at the beginning with the statistics, eating disorders actually have like the highest case mortality rate of any mental health diagnosis. So if you were diagnosed with an eating disorder, the likelihood of you dying from it is higher than any other mental health condition, which is striking. So I don't know the percentages of geriatric. Does that answer the question? Hopefully.
Yeah, there's no
All right.
follow-up yet, so hopefully that answers it. Thank you.
Okay, so one of the things that I want to talk about really quick, because there is that misconception, and we'll go here really quick, because I think this is something, when somebody thinks of anorexia nervosa, they think of these images right here, where they're extremely skinny, and that is not always the case. Like I said in those statistic slides that I shared at the very beginning, only 6% of people with a diagnosed eating disorder fall into the underweight category, and this is like severely underweight. This isn't just underweight. Most people with eating disorders appear to have like healthy, bone structure, different things like that. So if we look at the body mass index chart, anything from the green up is not. So the green is healthy weight, yellow is overweight, orange is obese, red is extremely obese, and the blue is underweight. And so they go into like sections. So like 18 to 17 is considered like a mild case. BMI between 16 to 17 is moderate. Severe is 15 to 16. And then anything under 15, so 14 and under, would be considered extreme. And that's the stuff that we see those pictures that are like, oh my goodness, that's crazy. So the majority of Americans are overweight or have obesity. So this is the percentage of American adults with a BMI over 30. So it is growing drastically. 1962, there was only 13%. 2018, it was 42%. And the percentage of Americans over age 20 who are overweight or have obesity. So again, with this, overweight or obesity is just yellow or higher, is 73%. As a country, we are continuing to gain weight, which is only adding to the diet culture and the prevalence of eating disorders. And so here is kind of a percentage breakup of all these different things. So like normal weight is it's 38% of the population. Underweight is only 2% of the population. So there's not very many people who kind of fall into that category. Some of the signs and symptoms that you're looking for you see some of these in therapy. A lot of it you're going to have to ask to assess for. Some similar with like suicidality, like you're not going to like see the fact that they're suicidal. You would be able to see more so like, if they're having any like physical symptoms of the eating disorder, but most of the time it's asking the questions and finding out like their behavioral responses. So change in weight, loss or gain that is significant. Again, they don't have to be underweight for it to qualify as an eating disorder. Obsessiveness over food, so a lot of calorie counting, anything like that. Change in eating habits. So if before they're like, oh yeah, I used to eat 3 meals a day, now I only eat once a day, and I'm trying to do intermittent fasting. Like any type of diet philosophy or diet stance, even though diet culture is very common, I just like to assess it to kind of see if it's a healthy diet or not. Withdrawal from friends or social gatherings. This could be due to the comorbidity of eating disorders, but also could be tied to just not wanting to be around friends while you are eating. A lot of Americanized social gatherings socialize around food. So there's a lot of withdrawal from that. Because you're not taking in as many calories and you're not feeding your body what it needs, there's a lack of energy. Now, depression, like we talked about, there's an extreme concern about appearance or dieting. There's avoiding eating around others. Sometimes if it gets really intense, or if you are having very little intake of calories or nutrients, there can be dizziness or fainting, loss of a menstrual cycle. This once upon a time was in the DSM-4, but they took that out. You don't have to have lost your menstrual cycle for it to be classified as an eating disorder. Constantly cold, low blood pressure, mood swings, dehydration, dry skin, and then the thinning of hair loss, dry skin, also known as lanugo. So this is a picture of lanugo. Lanugo is the if anybody's ever seen like a little baby animal that was just barely born and they have this kind of fine layer of hair around their body, that is what lanugo is. People with eating disorders develop it in areas of their body that like hair doesn't typically grow. So on your face, your stomach, just random places, it's just kind of this thin layer of hair to kind of keep you warm. So some of the health risks that are involved with anorexia, so you can have anemia, heart problems, arrhythmia, slow heart rate, heart failure, kidney problems, low blood pressure, electrolyte imbalances, lack of menstruation, low testosterone in men, bone loss, and ultimately that can lead to death. So I'm going to go a little quicker over some of these because I want to be able to get to the treating place. So again, anorexia affects your whole body. It's not just something that affects your internal organs or your brain. It's like the entire body is affected, even the hormones, your body fluids, everything. So refeeding syndrome, this is something specific to anorexia. Refeeding syndrome is, sorry, I've printed out my notes and for some reason I am not able to find them here. But anyways, refeeding syndrome can happen when someone who has been malnourished begins feeding again. If food is introduced too quickly, it can cause serious complications. So thinking about like somebody who has experienced alcoholism for a long time, even though you want them to stop eating, you don't just like take away the alcohol altogether. It could cause seizures, it could cause like shakes, all sorts of things. So it's this gradual process of like weaning them off of alcohol. So with the refeeding syndrome, it's a gradual process of introducing new foods. So again, at my work with the clients at the residential treatment center, some of them had come in only eating a few hundred calories each day for the last few months. They are super skinny, very sick, very frail, very fragile. And they would get on a diet plan of like 400 calories that day. And then the next day it's 450 or 600. And then it was like this gradual process. Within like usually 2 weeks to 3 weeks, they were up to like 12 to 1500, and then after a few months, they were up to kind of like the weight gain process, which is never a fun process for somebody who is terrified of becoming fat or overweight, but it was essential. But it's just kind of something to be aware of as well. Just telling them, oh, well, you haven't been eating for the last 3 months. Well, go, eat a Big Mac or something at McDonald's is not going to be good for their bodies. So next we're going to go to bulimia nervosa. So bulimia nervosa, recurrent episodes of binge eating, is characterized by both eating within a 2-hour period, an amount of food that is definitely larger than most individuals would eat compared to others, and feeling that you cannot stop eating. So there's a compulsive nature to this. So you feel kind of out of control. You don't know, you can't make yourself stop or control how much you're eating. There's also recurrent inappropriate behavior to prevent weight gain, such as self-induced vomiting, misuse of laxatives, diuretics, or other medications, fasting, or excessive exercise. The binge eating and inappropriate compensatory behaviors occur on average at least once a week for 3 months. Self-evaluation is unjustifiably influenced by body shape and weight. There's 2 categories here that we try to specify, both either purging type, which is the person is regularly engaged in self-induced vomiting or the misuse of laxatives, diuretics, or enemas, or the non-purging type. But during this, the person has inappropriate behavior such as fasting or excessive exercise, but does not regularly engage in vomiting or misuse of laxatives. The severity of this is based off of how frequent either the vomiting or the diuretics and everything is used. With bulimia, typically there is the binge aspect of it, but it doesn't always have to do that. Sometimes it's just kind of like you can't control or stop eating. And one of those caveats with like the other, what was it called? So like on the diagnostic criteria, if it was, sorry, I'm trying to find it in my notes because my computer and I'm not. So the other 5 specified feeding or eating disorder, the OSFED, just kind of like the bulimia or the purge disorder and absence of binging could be listed here. So bulimia, there does need to be that binge episode where if that's not occurring and they're just purging, that would be the purge disorder and absence of binging to maintain weight. All right. Signs and symptoms of bulimia nervosa, evidence of binge eating, eating alone, then skipping meals, evidence of purging behaviors, using the bathroom immediately after eating, excessively rigid exercise regimens, unusual swelling of the cheeks and the jaw area, calluses on the back of the hands and knuckles from self-induced vomiting. This is called the Russell sign. Here's a picture of it right here. I don't think that alone would indicate, because some people have calluses on the back of their hands or knuckles, but it is one sign to kind of look at. Discoloration or staining of teeth, creation of lifestyle schedules and rituals to make time for binge and purge sessions, and then withdrawal from friends and activities. Some of the health risks for bulimia is electrolyte imbalances that can lead to irregular heartbeats and possibly heart failure and death. Dehydration and loss of potassium and sodium from the body as a result of purging behaviors. Inflammation and possible rupture of the esophagus from frequent vomiting. Tooth decay and staining from the stomach acids released during frequent vomiting. One of the symptoms is like really bad breath with that as well. And then chronic irregular bowel movements and constipation as a result of laxative use. Again, bulimia is a full body condition. It affects everything to your skin, your brain, your hormones, your mouth, your throat, a lot of burning, the acid reflux aspect. So it can really like hurt your stomach and your intestines. And then it affects your hormones as well. So binge eating hysteria, the criteria of 1 and 2 are the same for both bulimia nervosa and binge eating disorder. So the episode of binging, of eating within a 2-hour period, an amount of food that is more larger than other people would consume. When I'm working with clients with this, I often will talk to them because they're like, I want to know how many calories it's actually a binge. And so it's twofold, because like some people can put down more calories, and it depends on like age, body, and like body size, different things like that, like how many calories you need per day. Typically what I go though is like, if you're consuming more than half of the calories that you're supposed to consume in a day for your body size and weight. So if the average person is supposed to do 2,000 calories and you consume 1,000 calories in a setting, that might be considered a binge, but then there would have to be these criteria as well, like you don't feel like you're able to control it, or you can't stop eating, or any of those things. Most of the time when people are binging, they consume over more than 1,000 calories. It's a significant amount, like between like 1,500 to 2,500. The binge eating episodes are associated with 3 or more of the following: eating much more rapidly than normal, eating until feeling uncomfortably full, eating large amounts of food when not feeling physically hungry, eating alone because of feeling embarrassed by how much one is eating, and feeling disgusted with oneself, depressed, or very guilty over eating. Other criteria, there's usually a big sense of distress regarding the binge eating, so they're very shameful about it, they regret it. Binge eating occurs on average at least once a week for 3 months. Again, the severity here is based off of like the amount of binges. So it says once a week would be needed to be able to be diagnosed, but mild is 1 to 3, moderate is 4 to 7 binge eat episodes per week, severe 8 to 13, and extreme is 14. The binge eating is not associated with the regular use of inappropriate compensatory behaviors, such as purging, fasting, or excessive exercise, because that would fall into the categories of either anorexia or bulimia. So signs of binge eating disorder: typically they eat until they're uncomfortably full. At this point, so with anorexia and with binge eating disorder, you can stop having like, your body stops trusting you and you don't have the hunger cues that you usually typically do. So part of that refeeding phase and eating in a healthy way is like learning to trust your body. And we'll kind of talk about that a little bit more as we go on. Oftentimes they're eating to ease stress and anxiety. So they're eating because they feel nervous, or they're eating because they feel sad. There's some type of emotion that is like triggering the eating. There's often like a very high priority on like recording the weight fluctuations, or like noticing like, am I going up or down? Consuming excessive amounts of food in short periods of time, feeling desperate to control eating and lose weight, and then self-disgust, guilt, and depression after binge eating. So just like an addiction, there's a really strong shame cycle that exists with eating disorder. There are a lot of things that contribute to eating disorders. There's environmental factors, biological factors, sociocultural, and interpersonal factors. A lot of times these overlap. I kind of broke them into 4 slides, and we're going to talk about them a little bit. But a lot of time, the contributing factors, I like to talk about how there's like a root cause of an eating disorder. There is an awesome podcast, and I linked some resources later on that I will show you guys that talks though about, it says that eating disorders are not the problem, they're the solution. What I love about that is they're saying that I don't think eating disorders are truly like the solution to like our problems, but eating disorders are become the solution. Just like there's a theory that some people who experience suicidal thoughts, they don't do it because they truly want to kill themselves. I mean, some people do, but there is that I feel so overwhelmed, my body doesn't know what else to do. So it's like, oh, I have an idea. You could kill yourself. Like, is that a good option? No, but is that like your brain trying to come up with a solution or a possibility? Definitely. So with eating disorders, it's the same thing. Like, I don't know how to control the situation. I feel so overwhelmed. I feel so sad. And so they turn to their disordered eating or eating disorders to as a solution, as a maladaptive coping strategy for managing the root cause. So a lot of the root causes, low self-esteem, poor body image, anxiety, depression, peer pressure, media pressure, and exposure to people with eating disorders, the biological aspect of that, like if your mom has an eating disorder, or if there's a lot of talk, negative food talk, or a hyper focus from your family or peers about being skinny or not eating unhealthy foods, sometimes that can lead to disordered eating. So breaking it down a little bit, so family dynamics, like I was just talking about. So if you notice that a parent or somebody within your family, sometimes it's a grandparent, sometimes it's an uncle or aunt, sometimes it's your mom or dad, but if they have an extensive like history with dieting, yo-yo dieting, if they have like a huge focus on being skinny, or if they beat themselves up, if they're constantly negatively talking about their body, saying that I'm fat, I'm ugly, all of that bleeds into their children, where they are witnessing that and start wondering if they're fat or if they should diet, or if mom feels that way and I think mom's beautiful, like, and she says I'm beautiful, maybe I'm actually fat and need to start dieting. Traumatic events, traumatic experience such as death, bullying, physical or sexual abuse, or other forms of trauma can trigger disordered eating as a coping mechanism or a way to regain a sense of control over one's life. Also, another theory is the fact that eating disorders emerge as a way to numb or avoid feelings, and this can be achieved through calorie restriction. Stressful life events, moving, parents' divorce, natural disasters can trigger disordered eating behaviors as a way to cope with emotions or regain a sense of control. And then occupational or academic pressures or athletic pressures. Certain occupational or sports that emphasize weight, appearance, or performance standards may contribute to the development of eating disorders, particularly in individuals who are highly competitive or have perfectionism. Sociocultural factors. Here I focus more on like the cultural ideals of beauty. So there's a strong cultural pressure that, you know, within America that glorifies thinness, and they place a value on obtaining the perfect body. There's narrow definitions of beauty that include only women and men of specific body weights and shapes. Individuals may internalize these ideas and strive to attain them, leading to disordered eating behaviors. A lot of the media portrayals through mass media, magazines, television, movies, social media, they frequently depict thinness as a standard of beauty. The exposure to these images can lead to body dissatisfaction and the adoption of unhealthy eating habits in an attempt to achieve the desired body shape. The hardest thing about this, and I love that people are trying to be more aware of this, like they post like with like the Dove commercials, where it's like, and there's more than a body commercials. There's a lot of things that kind of show that like all bodies are beautiful. They're trying to have like more body positivity. And these images, like these are just some photoshopped images. This is a plus size model who they thought was like really pretty, but then needed to make her very thin, and they still call her a plus size model as they are advertising this, which this girl is not plus size by any means. And again, taking a plus size model, making her look like this, and then telling people that this is plus size and make them really self-conscious. Let's see, peer influences are really strong here, both with social media and just in general. Friends dieting, friends trying, just like self-harming, eating disorders, part of it can be considered self-harming. So when you're purging, when you're restricting, that's harmful to your body. It is a social issue. If your friend's like, hey, like, don't worry, I know how to like solve that. Like, hey, let's go to the bathroom and throw up together. It becomes a social thing, but then the addiction pursues. There's a social comparison, feeling like, oh, they ate that much and are that skinny. Like, I want to eat that much. And maybe if I throw up, I can still be that skinny, or I just need to be able to work out like this person does, and then I can be that skinny. So biological factors. So there is a lot of research that goes into talking about how genes play a huge role in the development of eating disorders. They impact everything from someone's particular biology or the way their body is built and functions to their genes themselves. Studies suggest a heritable component to eating disorders, with individuals having a family history of eating disorders being at higher risk. There's neurochemical imbalances in neurotransmitters such as serotonin, dopamine, and norepinephrine have been implicated in the development of eating disorders. A lot of times when people do have binge eating disorders, binging, there's like a brain-gut connection with dopamine. So when you eat the food, there is dopamine in your stomach that gets shot up to the brain, and it is like this like happy burst. And then it adds to that cycle of addiction, in addition to the cycle of shame. The predisposition to co-occurring mental health conditions. So if there is that biological aspect of family having depression or anxiety or OCD, they're more likely, or ADHD or diabetes, like some of those things we talked about, the likelihood of them developing an eating disorder is higher. There's metabolic factors, hunger signaling, fat storage, that is very much genetic based. And then the brain structure, the reward processing, emotional regulation, self-control, that too can be attributed to genetics and biology. And then we'll go into the interpersonal factors or aspects of eating disorders. A lot of times troubled family and personal relationships. So if you're feeling stressed or overwhelmed, don't feel like you can turn to your parents, or feel like the parents are the root of the problem, then they try to handle things on their own. And one of the results can be eating disorders. Sometimes if you struggle expressing emotions, feelings, you don't have a lot of body awareness, or you don't feel safe expressing those emotions, it can then turn into disordered eating. If you have a history of being teased or ridiculed based on size or weight, as we talked about with those facts at the beginning, again, I think it's like, it was 40 or 60, somewhere in between there. It was around like the halfway mark of people who are teased kind of dabble in disordered eating or experience some form of disordered eating. People with a history of trauma, sexual, physical, and or mental abuse have a high risk of eating disorders. This says 60 to 75% of bulimia and nervosa patients have a history of physical and or sexual abuse in their past. Romantic issues, relationship issues, or even just like platonic friendship issues can cause a lot of eating disorders if you don't feel good enough, or if you feel like they would like you more if you were skinnier, if they would like you more if you were prettier, and the support system or lack thereof. Some negative beliefs that people hold about their body. You exist for others' viewing pleasures. Your happiness and self-worth is directly connected to your body size. The likes you get on posts, follows, and DMs, again, they assume that is associated with self-worth and their body size. They feel like their looks are more valuable, or their most valuable asset. They believe that their body will earn them love, popularity, and self-esteem. We believe our bodies are to appear pleasant to others, or we are ugly or have failed. And we live to be looked at, or self-objectification. So a lot of things, a lot of people feel like, you know, when there's a problem, it's because I'm skinnier. It's because, or not because I'm skinny, it's because I'm fat, it's because I'm not skinny enough, or it's because I'm not pretty enough, or if I was skinnier, I'd be prettier, especially because that view of thinness equates to beauty. They have that mentality. Some positive body talk. A lot of the work that I do with clients is to change their self-talk, is to kind of identify other positive things that your body can do. So your body is an instrument, not an ornament. So being able to identify that, like, our bodies are tools to be able to do certain things. Like, I have to have enough energy and strength to be able to run a marathon. I have to be able to be strong to care for my children. Anything that can kind of like empower and make you feel like my body is more than just something to be looked at. Recognizing you don't have to thin to be valuable. Our value is based upon so much more. There's a lot of great books that talk about instilling self-care, or not self-care, but self-worth and self-value. More Than a Body is a great book that talks about a lot of positive body talk. Recognizing that healthy is better than thin, and you are enough as you are. So,
Mandarin, before we
Yeah.
jump to treatment, we do have a couple questions in the chat that are specific to diagnostics.
Okay. Let me look.
So the first one, if someone has lost 20 to 30 pounds intentionally because of thoughts of being fat, but they are within a healthy weight for their age and height, would they meet criteria for anorexia, or would that be atypical anorexia?
So it depends. So it's more than just the weight loss. So if we went back to the criteria aspect of things, it depends on their mindset. So yes, they might have felt like they were overweight, and they literally might have been overweight. So people who go to the doctor and have high blood pressure, or people who go to the doctor and they say, hey, you're a little overweight, you have high cholesterol, like if we drop some of this weight, you'd probably be healthier. So sometimes they do it because they truly believe that they're overweight or obese or fat. Sometimes that's a synonym for it. But it's like with anorexia, there's like this like overarching fear of gaining weight. So some people are like, well, I don't want to gain the weight back, but it's not like a true fear of that. So that is one of the aspects. Let me go to like the criteria really quick, because there's several other criteria for it to fall into that diagnostic part. And I'm sorry that I am not as organized as I wish I was. So let's just go back. So again, that intense fear of gaining weight or becoming fat, disturbed by one's body weight or shape. So there's like your self-worth is damaged because of it. You don't think that like if you lost more weight, then it would be a big deal. A big part of it with eating disorders is having this like, once you get to a certain weight, that's never enough. And you always have to go lower and lower and lower. So say that somebody's 160 and they want to be 140 or 130 because that would put them in the healthy BMI range. And then all of a sudden they get to 130 and they're like, oh, but I need to lose another 10 pounds. And then they get to 120 and they're like, I still need to lose 10 more pounds, because they're never actually satisfied with the shape of the body or the size of the body. Their self-worth still stinks. They're still feeling like they have like body dysmorphia. Body dysmorphia is like when you think that you're a certain size, but then when you look in the mirror, you assume that you're a lot bigger. So there's a lot of different aspects that also apply to that. So just losing weight is a very common thing that people do. And a lot of times there is healthy, it's healthy. So no, it doesn't meet criteria for that. It's more about the mindset that goes along with that, or that, you know, is this enough? Or is the goal to be healthy, or is the goal to be super skinny? Is the goal to be healthy, or is the goal that I have to lose weight to be able to be beautiful or to feel loved or to feel good enough? You know, while you're losing weight, there's also a mindset to it that we're going to talk about. Like, are you doing it because of the addictive cycle? Because when I lose weight, I can mute my emotions. Am I not eating, or am I limiting what I eat because my hope is, you know, to make it so I don't feel hurt, or I don't feel anxious, or I don't feel shame? So hopefully that answers that question. Let's see if there was more.
Yeah,
Is there
so the
data?
next one, yeah, is there data on the increase of weight gain due to COVID-19?
That's a great question. I don't know. I don't know that one.
And then the last one is, what is your opinion of the BMI? Much of what I hear from HES and other ED certified professionals is that BMI can be an indicator, but isn't always reliable.
100%. Yeah. So the way I use the BMI scale is purely for psychoeducation. Typically when I'm using that is to show people like, you are right now on the verge of being underweight, or you are an average weight. Like, and then I show them like how many people are overweight. Not that like, you know, they want to, a lot of times they recognize like, well, I don't want to be fat like everybody else too. The BMI, it doesn't take into account like muscle mass or water weight or any of those things. It truly is like weight to height ratio. And then it just falls into a number. So there's other helpful things that you can kind of assess to be able to identify if they are not a healthy weight. But again, like, I use it more for psychoeducation pieces to show people, because typically people with eating disorders always feel that they're way fatter than they are. So when I show them like, this is the range for a healthy weight, they're like, oh wow, they're really shocked by it. So yeah, BMI is not like the sole indicator. It's more just a helpful resource. Any other questions on BMI?
I think those are all the ones in the chat, but yeah, if anybody else has questions, feel free to ask now.
All right. So we will go into treatment approaches and some of the things here. So a couple of things that I like to ask clients or assess while they're in session, and sometimes, not even sometimes, most of the time, people don't come in strictly for their eating disorder. And sometimes they do, but eating disorders come with like a high rate of people who are in denial or who don't think it's a big deal, or they're being pressured to come in for therapy if it was like for their eating disorder. But a lot of times they don't come in intentionally saying like, hey, I feel like this is a problem. So some of the stuff that I like to talk about is I check in with their body satisfaction, just, and some people can incorporate this into their intake assessments or any of those things. I do have some specific like assessing tools, and some are as short as like 5 questions that we're going to get into here in a bit that are really helpful in kind of gauging this. Asking about diet culture, family, community, friend groups, just like growing up, like what were you taught about food and diets and like healthy eating. Ask about weight maintenance. Like, I like to ask this question too when I'm screening for depression as well, just kind of like, have there been any significant changes in weight gain or weight loss? Also, when people are on medications for, any SSRIs or any of those things as well, like this is a helpful indicator just about what's going on in their bodies. Asking about eating habits. So like if they're constantly coming in, I had one client who would constantly come in and their stomach was growling. They were coming in for something completely different. It was trauma related and their stomach was growling all the time. And so I was like, oh, so I had granola bars out of my waiting room. And I was like, would you like a granola bar? They said no. And I asked like, well, when's the last time you ate? And they're like, oh, well, I missed breakfast. And it was like 4 o'clock in the afternoon and they don't eat during school. So I was like, is that like a common thing? Like, what does your typical day look like? When I go through a typical day scripts, just in general for people to kind of get an understanding of what their daily routines are. I always ask about eating as well. Like, do you typically eat breakfast? Like, how do you stay awake when you have young kids? Like, how high is your caffeine intake? Different things like that. And it doesn't have to be a judgy thing like, oh my gosh, you look skinny and I'm worried you have an eating disorder. It's just, these are questions to ask to assess if further assessing needs to happen. And then I always like to know how they cope with difficult emotions or stress. If their answer is like, I cry and eat a bucket of ice cream, and sometimes they laugh over that. But then, we go into furthering questions of like, how often does that happen? Or when you say you eat a gallon of ice cream, like, are we truly talking like the whole gallon or just a bowl? Or if you cry and eat a bowl of ice cream, like how many bowls are we talking? How big are the bowls? And then assessing for trauma just due to the high comorbidity rates. Some of the assessing tools, So we have the eating disorder examination. This is given by clinicians. Then the eating disorder examination questionnaire, and that's filled out by the client. So these are the 2 most common and most popular ones, and they do a thorough job, and they were created with the DSM-5 in mind and the diagnostic criteria. So it really hits at those diagnostic criteria. The hard thing is with the self-report of this, it makes it more difficult because again, there's a lot of deceit, there's a lot of lying, there's a lot of hiding, partly because of the shame, but also partly because these are coping skills, even though they're maladaptive, that have kept them alive or have kept them safe for the last 20 years that they've been engaging in this behavior. So there's a lot of reasons that people keep this secret, but eating disorder examination, you can look that up, it's free online. The questionnaire for eating disorder diagnostics, this used to be kind of like the primary go-to one, but it captured the diagnostic criteria for the DSM-4, so it's kind of outdated at this point. The eating attitudes test is a 26 questionnaire, again, self-report, so the clients fill it out, but it gives a whole bunch of questions just about like healthy eating, disordered eating to kind of understand how they go about that. The SCOFF questionnaire and the eating disorder screener for primary care physicians I have here, so I want us to go over them. So both of these are just 5 questions, and it can kind of give you a quick idea of what you're working with or any of those things. So if you ask a question that makes you kind of pause or makes you wonder if eating disorders could be a part of what we're dealing with here, I would throw out one of these to kind of get further details. So the SCOFF is labeled just because they take the SCOFF, but do you make yourself sick because you feel uncomfortably full? So it's very directly just asking these things. Do you worry that you have lost control over how much you eat? Have you recently lost more than 1 stone, which is 14 pounds in the last 3 months? They only say that, so it fit into the SCOFF thing. I wish they just said 14 pounds. Do you believe yourself to be fat when others say you are too thin? And would you say that food dominates your life? The eating disorder screener for primary care. So this is usually filled out, or this is what kind of doctors use or physicians, family physicians use. Are you satisfied with your eating patterns? If they answer no, so these are just yes or no questions. And if they get more than 2 no or 2 kind of concerning answers, then they will do further assessing. So if they say no, then that is considered a concerning. That would be like one of the 5. Do you ever eat in secret? Again, if they say yes, that would be a concerning answer. Does your weight affect the way you feel about yourself? If they say yes, would be a concerning answer. Have any members of your family suffered with an eating disorder? If it's yes, due to kind of the genetic predisposition that we talked about, that would be concerning. Do you currently suffer with, or have you ever suffered in the past with an eating disorder? So with these screeners, I don't know, Teresa, are you going to be handing out these slides after this?
Yes, that'll go through in their follow-up email.
Okay, so I was going to say with this too, this page can be helpful in just kind of gathering those. So when it comes to treating this, like the ideal situation would be to have like a very holistic approach. When I worked at the Eating Disorder Treatment Center, they had all sorts of stuff. Like even though it was just the adolescent girl that lived there for the 9 to 18 months, the family, they would have families come, even though they weren't from the area, for like a week-long visit where they would do extensive family therapy. They meet with the family once a week via telehealth to do family counseling. A lot of psychoeducation is done because of the awareness. I think people minimize like how dangerous and how risky eating disorders are. They just are like, oh, they're not eating, but the malnourishment that can happen, the kidney damage that can occur, the gastrointestinal issues, like once those things happen, you can't turn back time, and you can't all of a sudden just stop the eating disorder and then renew your kidneys. Like permanent damage can happen. So they involve the family to really psychoeducate on the dangers of it, but also on like what are some of the triggers that are impacting this type of disordered eating. Trying to get at the root cause so that way they can increase the support system, make it a healthier, more adaptive support system, and hopefully get everybody into a better, healthier eating aspect. Getting a dietitian on board would be awesome. There's a lot of psychoeducation on like the importance of food, what type of food is healthy. When people have disordered eating, their whole concept of what's healthy and what's not healthy kind of goes out the window. I've worked with some people where they completely avoid carbs and other people who completely avoid meat. I work with some people who only eat, raw vegetables because if you cook it, they feel like it was taking away like the nutrients. And if they're only going to eat 400 calories a day, then they want to make sure that they're eating like the healthiest. And I work with other clients who don't care and they're just like, I can eat whatever I want as long as it stays under 1,000 calories. So a dietitian would be really helpful. Your physician, because it's going to look at all the other stuff. They're going to pull blood work. They're going to do hormone tests. They're going to do all sorts of things to kind of make sure that you're physically healthy on the inside. Like I said, family therapy and individual therapy, both helpful. Oftentimes, though, all we get is somebody coming for individual therapy who has a lot of shame, doesn't want to talk about their eating disorder with the outside support system. And so it's a much more long, difficult kind of road there. So as I talked about earlier, I think a big part of eating disorders are identifying the root problems. So people develop an eating disorder often to cope with the root problems. As I said, eating disorders become the solution to the problem. Even though they're maladaptive, they still are a coping strategy to cope with whatever is going on. Eating disorders help people numb emotions. They deplete or surplus the body with happy chemicals. So again, when people are binging, oftentimes they are adding a surplus of that dopamine. When they're depleting it, it's usually with anorexia, there's a high correlation of like a deficit in serotonin and norepinephrine. Some other root problems, trauma, academic pressures, medical conditions. So we talked about diabetes, but also like, I'll give an example here in a few minutes about somebody who had hypothyroidism. There's a lot of medical conditions. I've seen it with celiacs where like they're already limited on like what they can eat. and they start losing weight, and therefore, because of that, so it was like a secondary response to kind of the primary condition that eating disorder kind of starts developing, because they're like, oh, I haven't been eating as much, but guess what? I don't feel as anxious about X, Y, or Z. So they see the eating disorder serving the purpose of numbing emotions or making them not feel as lonely or feeling like they have control over something. So they don't have control over what they put into their body or the fact that their bodies are allergic to certain things. So then they start controlling how much they put into their body. Other factors: social media, family dynamics, genetics, cultural ideals, SES status, food insecurities, and the list goes on and on. So here are a couple examples to kind of give you guys an idea. These are clients that I've had over the last few years, just a few of them, but they don't always have to start out or have like a really unhealthy family dynamic. So this 18-year-old girl that I worked with, she was a swimmer on the high school swim team. She was super involved with she was good with academics. Her family was really engaged. She had the average BMI. She was healthy, active, pretty, popular. She decided to go for a bodybuilding competition her last couple of months of her senior year of high school. She went on a strict diet. She lost 14 pounds in 2 months. So when she started, she was like 5'6". She went from 130 to 116. At 130, she was in a healthy BMI range. So if we're using just the BMI, she was like right there smack dab in the middle of healthy for her height. She went to 116. At 116, she was just on the edge of underweight. So 17 and under is underweight and a really unhealthy BMI. And she was at, I think, like 17.6 with 116 at 5'6". So once the bodybuilding competition ended, she started refeeding herself. She did not do this slowly. She was so tired of being so strict about her diet that she started just eating a lot more food. She felt fat. She realized that she wasn't feeling good because the restriction of the weight numbed a lot of her emotions. So she started eating, and then she felt horrible about herself. So she began throwing up when she started eating normal. Also, with this period of 2 months of her having a pretty strict diet, she stopped having hunger cues. So hunger cues are like letting your body know that, hey, I'm hungry, or hey, I'm full. And when those go away, it can be extremely confusing to your body. You don't know if you're hungry or if you're full. Sometimes you just stop eating because you're like, hey, my stomach hasn't growled. I don't feel hungry, so why eat? Other things too, she was like, I never know when I feel full. So she's like, if it tasted good, I would just eat it. And then she would look for times to throw up because she's like, I just ate 4 Navajo tacos and that's not healthy. Purging became very addictive and cathartic. She didn't have to feel. Purging helped manage her stressful academic and athletic pressures. So she saw it as a byproduct as well. The maladaptive coping strategy helped with school stress, athletic stress, and family pressures. So I had seen her there for a little bit prior to her coming back in for this eating disorder. And she didn't even come in saying, Mandarin, I have an eating disorder. She came in just saying like, hey, things have just been kind of a little harder lately. I've been a little stressed, even though I feel like I'm handling it better. I'm worried about a few things. And so it took a couple of sessions to ask, or just talking to her and assessing, before I was able to identify okay, we have an eating disorder on our hands here. She was able to kick it. A lot of it was through the psychoeducation. She didn't realize being a very healthy, active, pretty popular person and loving swimming and wanting to be healthy enough to swim, she was able to kind of kick the addiction and knowing that she wanted to be healthy enough and have her body do everything that it needed to do with swimming. She involved her mom, which she was super shameful and embarrassed about, given the fact she was 18. I couldn't talk with mom because of confidentiality restrictions. So I was really proud of her for talking with mom and having her support system involved. And they came up with a plan to make sure that she was being checked in on a regular basis. Another example of somebody I had a 12-year-old girl. Well, she came into therapy at 24, but at the age of 12 years old, she went to the doctor truly for gastrointestinal issues. She was extremely constipated. She wasn't being able to go to the bathroom, and it was causing severe stomach cramping. So she was put on Miralax. With the Miralax, she started to drop a lot of weight. Initially, it was just the bloated weight because she was extremely constipated and backed up. And as she was taking it, they told her to take it for a certain period of time. I can't remember exactly because it was a while ago. But for whatever reason, the losing weight, developed compliments, all the things that happened, and it sent her on a journey of over 12 years struggling with the purging via laxatives. She was in and out of remission until she became married. So she came into therapy at 24 because she was having issues with her in-laws. So at this point, she was 24, she was married, she had healthy BMI. She couldn't just saying like, I don't feel appreciated, I don't feel accepted, I don't feel good enough, I don't feel loved by my in-laws. So we talked about that, we talked about a lot of things, and then all of this kind of unfolded, and she was more like, anytime I hang out with my in-laws, I go home and I take laxatives. I don't know how to control how I'm feeling. Her eating disorder 100% gave her a sense of control, helped numb her. So she would often do it before she went to a family gathering and then after as well, to just kind of numb the emotions that she was experiencing. Unfortunately, I didn't get to see her through treatment. She stopped coming to treatment. And I don't know, she struggled with this eating disorder for 12 years, like I said. My hope is that she developed healthier stuff. She, upon leaving therapy, before she stopped coming, she had recognized that it wasn't healthy. She was doing certain things, relapse prevention strategies, and we had done a lot of work to kind of heal some of that past trauma that she had. We talked about that fear of like, you know, she had associated gaining weight with also developing gastrointestinal issues. So I'm certified in ART and EMDR. So we did ART on that, where she felt a lot less anxiety about, hey, if I gain a couple pounds or if I eat a big meal, it doesn't mean I'm going to become constipated and have gastrointestinal issues. Well, other examples, a 36-year-old man. So he came into care at 36 years old. He started therapy due to relational issues, lack of connection, intimacy with wife. Realized he has been dealing with stress and his insecurities by compulsively binging for the last 20 years. Binge eating gave him a lot of dopamine releases and helped him feel better temporarily until he didn't anymore, which would result in another binge. So again, I'm sharing a lot of these things of like how it started. They came into therapy, not nobody, but it's very rare that they come in because of their eating disorder. And when they do come in because of their eating disorder, typically it is because their parent is concerned or their spouse is concerned, or it's not because they're concerned about themselves. So a big part of it is like using kind of that stages of change theory or the motivational interviewing and kind of helping have kind of a secondary gain to getting into a healthy spot. And that's where that psychoeducation piece comes in a lot. Another client, I kind of mentioned this one, diagnosed with hypothyroidism at 26, started gaining weight because of it, went on a strict diet and medication from her doctor to help with it, began losing weight, received a lot of compliments in addition to the numbing effects of losing weight. She finally felt like she had some control over her health. Even once hypothyroidism was managed, she couldn't stop a hyper focus on restriction, and the urge to lose more and more weight, was fearful of gaining it back, developed anorexia nervosa. And it became a sense of control for her. She still struggles with disordered eating. She is at a healthy BMI, and she really makes it so she's not going to get to the point where she is malnourished, but it is a constant struggle for her. Some interventions that I do on a regular basis. When somebody identifies that they have an eating disorder, or when I identify for them, it sounds like you're doing that, you know, for this reason, or it sounds like, you know, this could be characterized as disordered eating. And I often gently kind of go into it at first to kind of just see their reactions and call it disordered eating before I say you have an eating disorder. But I have them write down what they are eating. I get a lot of resistance for this because people who have eating disorders will sometimes say, well, if I track it, then make them more hyper-focused on it. So other people can feel differently. I feel like that is an excuse. So I have them write down their calories more so I can see what they're eating and seeing how much and when they're eating it. One of my goals in some of the psychoeducation I do is to help them avoid starvation mode. So starvation mode is anytime you deplete your body of a certain amount of calories where your body stops having those hunger cues. So when somebody is in starvation mode, again, they don't have hunger cues. Oftentimes they start to feel like their tummy's getting a little pudgy, or that they're holding a lot of their weight in their stomach. And that's because when your body stops trusting you that you're going to feed it on a regular basis, or it doesn't know what to expect, it will start hoarding those calories or hoarding that fat around your essential organs. It's like a survival mechanism. So again, that psychoeducation piece is very integrated into a lot of the interventions that I do. I'll have them track their food and emotions while that come while eating. I have them track when they eat. A lot of times I'll assess for body dysmorphia. So I'll have them draw a self-portrait to assess for body dysmorphia. Oftentimes at the eating disorder treatment center, they would have like a measuring tape and they would like roll it out and say like, how big you think your leg is. And then they would measure it and we would like write it down and then we'd have them actually measure their leg. It was never, like, I never saw it where somebody like underestimated it. Everybody always overestimated how big they were. Again, these were people with pretty severe eating disorders, but like the prevalence of body dysmorphia was extremely high. Coming up with a relapse prevention plan. So next time you want to numb, avoid feeling, what will you do instead of purging? What will you do instead of restricting? What will you do instead of running 10 miles? And what's so hard about eating disorders, and I think this is something that I wish that more people knew. If you had an addiction, if you were addicted to cocaine, if you were addicted to meth, if you had an alcohol problem, then we would say the next time you want to drink alcohol, what will you do instead? Next time you want to do this, what will you do instead? And a big part of 12-step groups, a big part of like overcoming addictions is avoiding triggers or avoiding the problem. When it comes to food-based addictions or eating disorders, you can't avoid food or you can't avoid feeling sad to solve the problem. So with this, you have to like really develop that healthy relationship with food. You have to identify like what your triggers are. And for a lot of people with binge eating disorder or that bulimia where there's that binge purge dynamic, there's certain foods that they would binge on. So usually it's something like very like either sweets or salty. So like chips would be a primary one, or fast food, or a whole cake, or not whole, well, a whole cake, or I was gonna say a whole pan of brownies.
Insurance company. I should.
Sorry, does somebody have a question? Oh, all right. So it's hard to avoid eating disorders or food related things, even though it is very much that addictive pattern. I like them to identify their triggers. I always say you have to name it to tame it. You have to be able to know what your triggers are to be able to have a plan for next time it happens. I like to involve their support system. It's easier if you have support, just like with any 12-step groups, like doing stuff on your own is way more difficult. Even if you have an accountability person, it holds you accountable. Increase self-awareness and body awareness. This is going to be a huge part of eating disorders. So with eating disorders, a lot of that goal is numbing. So they'll find when they decrease intake or when they are binging, a lot of those are numbing activities. So being able to have that self-awareness of what is happening, what am I doing, how am I feeling, using DBT skills, mindfulness skills, acceptance and commitment therapy, doing body scans, all of that stuff can be very, very helpful in increasing that self-awareness and the body awareness. When I do have people who are tracking actively, and they're willing to do that, the next step is like, okay, let's do a body scan and see how you feel before you eat, how are you feeling while you're eating, and how do you feel after you eat. So if they can do that in those 3 phases, it'd be really indicative of like where the problems are. So some people struggle identifying those triggers. So even doing some of those body scans throughout the day to be able to identify what am I feeling, why am I feeling this way, would be helpful. With eating disorders, we talked about that impulsive or compulsive urge that kind of follows it. Specifically with like binging, it's very much like the inability to stop. Like you feel like this compulsive need to just keep eating, keep eating, keep eating. The impulsivity is typically that like, I feel this, so I do that. I feel sad, I'm gonna throw up. I feel hurt, I'm gonna go run 10 miles. I feel angry, I'm not gonna eat dinner. So taking that 30 seconds for the intense urge to dissipate. So with a lot of the relapse prevention research, more so against like addictions and like drugs, they say for that actual chemical urge to go away, it only takes 30 seconds for it to drastically dissipate. That behavioral desire to feel that certain way will last a lot longer. But if you can have a relapse prevention plan or a strategy of like what you're going to do instead next time that thing happens, it's going to give you another form of control. Like, okay, normally I restrict, but I'm going to do this instead. Normally I binge on this after dinner, and I always want something sweet after dinner. So I always want those bowls of ice cream, and it turns into 6 bowls of ice cream or 6 bowls of cereal or what have you. So next time you want to binge, like Or if you're hungry, could you munch on carrot sticks instead? Like, I've never seen somebody binge on carrot sticks. Like, your mouth would get too tired because it takes so long to eat them. It's hard to chew. Or if you want to avoid food altogether, so say you're not hungry and anorexia is not your issue. So at that point, it's like, okay, next time you want to avoid, let's go paint a picture. Let's go draw, like really enlist those like identifying coping skills. And then identify and track the cycle of addiction with the eating disorder. So here's just kind of a sample, like with binge eating. So you feel deprived, maybe you had binged yesterday afternoon, so you haven't eaten anything, and now it's like been 24 hours, and you have this overwhelming urge to eat. Sometimes people even feel this, like if they just went too long in between meals. So like they hadn't eaten for 5 hours and they feel really hungry. Sometimes the deprivation is more like, it can be more emotion driven. This one is truly like hunger driven. And so then they start eating and they end up binging. They feel out of control and they feel ashamed. So they diet to regain that sense of control. And then the cycle happens again. Because of the dieting, they feel deprived, overwhelmed, and on and on. So again, I've talked about this a lot throughout, so I don't think we need to go into it quite that much, but identifying what is healthy, again, like that's where I use that BMI chart a lot, is kind of identify like what healthy looks like. I go over the dangers and risks of eating disorders, and then all of these things that we talked about, the hunger cues, starvation mode, hoarding calories and primary organs. So a lot of times people don't understand the what to what is happening. So if you can kind of help them understand that, awesome. If you don't know, refer them to a dietitian or somebody who does know, or do the research and kind of learn it right along with them. Other interventions. I like to externalize and personify the eating disorder. So it's not you, it's a behavior that you do. A lot of times people with eating disorders, I literally call it Ed. So like, so what's Ed telling you to do right now? Ed's telling you that you should skip the next 3 meals because you just had a binge. What would Sally tell you to do instead of Ed? Sally being kind of like yourself, your person-centered thing. I'm very eclectic in the way I work, so I pull from a lot of different modalities. So this is kind of using some IFS kind of part language. Again, like another great intervention is to identify the root cause, like why are we doing what we're doing? And that is just really like working backwards. Okay, so you binge. What was happening before you binge? Okay, what was happening before that? How are you feeling? What behaviors were you doing? Like back and forth before you can identify what were we trying to avoid? What were we trying to mute? What were we trying to numb? What were we trying to gain? And then heal the trauma. So again, like I use a lot of ART now. I'm both ART and EMDR certified, but with trauma, if you can kind of help them process that effectively, you're going to be able to then at least make it so that's not quite a trigger, but then you have to deal with the behavioral aspects of it. And that's where like the CBT and the DBT skills come in, of really like teaching coping skills to manage those difficult emotions. So this is a primary thing that I do. I like to discuss the changes of stage and the personal motivations that are going along with it. So with the stages of change, a lot of people don't feel that need to change, don't want to change. They're very contemplative or even just like avoidant of that. So really the psychoeducation helps kind of lean them forward into a better spot. And then even just normalizing, it's scary to give up their eating disorder. It typically has served a purpose and has helped you in some way. So I've alluded to this quite a bit, but there's a lot of parallels between substance use and eating disorders. They both serve as maladaptive coping mechanisms to numb emotional pain, to alleviate stress, to gain a sense of control. Both are impacted by environmental, biological, and sociocultural factors. They have shared behavioral patterns. So the impulsivity and the compulsivity is a very common thing that you see in both addictions and with substance use and eating disorders. So acting on the urges without considering the consequences, and then repetitive behaviors performed to relieve distress or anxiety. And there's a reward-seeking component, the pursuit of relief. Like any excessive exercise and binging equals a dopamine release. People call it the runner's high. With the binging, again, like the brain-gut connection, there's a release of dopamine. And then the purging and the restricting equals numbing emotions, dissociation. Dissociation on a small form, like is a coping skill, not necessarily adaptive, but people will do that to cope or to deal with stuff. And then the cycle of shame and guilt, very similar. Here are a few of the treatment approaches I use. Like I said, I am fairly eclectic and I use a whole bunch of different things. I'm not going to go over this case study because I want to make sure it was just another example that went into more details, but I want to make sure that I talk about some of these resources and then leave about 5 minutes for questions. So here's some great resources. I love her website. She is a therapist. She might even prescribe medication. She might be a psychiatrist as well, but she does like an eating disorder boot camp for clinicians to learn more about eating disorders. So she has a 1-hour one and also like a 36C EU credit hour one. And she, on her website, has a lot of awesome strategies. She very much feels like eating disorders is to like dissociate and numb out. And then this podcast by Rochelle Heinemann, Understanding Disordered Eating, is awesome as well. She also is a therapist and she does a lot of awesome work with eating disorders and interviews a ton of people to get better understanding of the different aspects of eating disorders. So thank you for listening, and any questions?
There are a couple questions in the chat that I'll read for you. So the first one is, how do you determine if someone is in remission versus recovery? What are the data points you use? For instance, if someone is still underweight, according to BMI, can they still be considered in remission if their mind is in a healthier place?
So that's multi-layered. So the second part of your question, no, you have to be in a healthy BMI to be considered in remission. There's, and I don't know if I want to like state it because in my head I'm worried I'm gonna get it wrong. There is a quantifiable data number for like the remission versus recovery, and it's a certain amount of time. Well, actually, I don't know if that's the case or not. Because like with addictions, again, if you think about addictions, like once an addict, always an addict. So like it's a constant, this like, you know, any 12-step group, and there's a lot of 12-step work with eating disorders as well, where they talk about like, you know, if I were to do it, if they say, hi, my name's Mandarin and I'm an addict, or hey, my name's Mandarin and I struggle with eating disorders. So because you struggle with disordered eating, it's going to constantly be something that you're going to have to work at. It's not going to be something you like recovered from. It could be something that like, hey, I've been in remission for 10 years and that's awesome. So that's how I would answer that.
Okay, the second question we have in the chat is, do you have anyone in the community, their community is Weber and Davis County, that you would recommend referring people to? And that could be expanded to even like, is there a resource list of folks that might be good for eating disorder treatment?
You know, sometimes they'll put it on their Psychology Today part where you can kind of like click on like things that you treat or work with. Unfortunately, there's a listserv. So I was listening to it in a podcast I was listening to the other day of like people who specifically work with eating disorders, but I don't know what it is off the top of my head. Maybe I'll look it up, and if I can find it, I'll email you, Teresa.
Yes, and I can include that in the follow-up email if you find it.
All right, any other questions from anybody?
Another one just came through the chat. How do you suggest helping a friend or family member that has many of the signs of one of these eating disorders, but has never talked about it or sought treatment before?
Honestly, I would do psychoeducation first, just in not like, oh my gosh, I'm worried about you and these are the dangers of like an eating disorder, but it can be through conversation of like, hey, I just attended this training. Like I had no clue that eating disorders were so dangerous. I didn't realize like the death rate, the fatality number, any of those things that might spur further questions, or even just saying like, hey, we like learned about like starvation mode. Did you know that you have to have a certain amount of calories so your body stops having like hunger cues? So it'd be more talking about it, but also like modeling healthy behavior as well.
Okay, so there are no other questions coming in the chat currently. But if anybody does have questions, feel free to hang on to the call. But I will give just my end of session information. In the chat, I put a link to the evaluation. That evaluation has to be completed to receive your continuing education credits. Then once you complete that, you will not receive a certificate immediately. It takes us about 2 weeks to process those, so you'll get it within about 2 weeks. But that's all you have to do is complete that evaluation survey. And then we just confirm your attendance. Also in the chat, I put in information about our upcoming session, which is focused on the topic of grief. It will be next month on May 17th, if I'm remembering what I put in the chat correctly. And it will again take place via Zoom, and the link is there to register. If you're interested in staying up to date on what is being done, both by the USU Social Work Department, who is the sponsor of our continuing education, you can follow them on social media, on Facebook or Instagram, or you can follow the Transforming Communities Institute, which is where I work, and we also share information about continuing education opportunities. And we have Facebook and Instagram as well as YouTube. All of our sessions, like I said at the very beginning, are recorded and edited to be put onto YouTube for later viewing. So if you want to just reflect on this or come back to the conversations we had, that's the best place to do it. But like I said, if you have questions for Mandarin or even myself, feel free to hang on the call. Otherwise, we appreciate you all being here.